Our next and the final speaker this morning, so Bob Keenan's coming back, and he's going to talk about inflammatory eye disease in RA and in rheumatic disease patients, and this is an area of his interest.
All right, thank you again. I'm back. So if you hadn't got enough of me this morning, I'm going to give you a little more. At least a different topic, though. And I should also disclose, and I probably shouldn't disclose such things, but you guys are the beta testing for this talk. So you're the first live audience I'm giving it to besides the wall. So the purpose of this talk is really, and I can change the name to Inflammatory Eye Diseases for the rheumatologist as well, because the purpose is to just remind everybody about inflammatory eye disease, and not only that, but hopefully you can gain something from this talk and actually be able to apply it to your patients and work in communion with the ophthalmologist and treat these patients appropriately, because the retina specialists around the country, and there's not a huge group of them, but the ones that are interested in uveitis typically do about the same things, and they typically don't like managing these medications if they can't help it. Most of them initially, unless they've been doing it a long time, aren't comfortable using the medications that we are comfortable using, and then the ones that are comfortable using it sometimes, quite frankly, scare me and how they use them. So, and I've gotten feedback from both the ophthalmologists and rheumatologists saying, well, it's difficult, the communication's bad, they're speaking Greek, I don't know what they're talking about in their notes, is this safe, or should we really give a patient this medication for, this disease? So hopefully by the end of this talk, you'll hopefully have a better appreciation and maybe be able to feel comfortable about co-managing these patients with the ophthalmologist. Disclosures, and I kind of hit the objective of the major objective of the study, the talk. So I'm going to start out with a patient case, and this is a gentleman we saw in clinic, in uveitis clinic it's probably a couple of months ago now. It was a 25-year-old gentleman who was in the Air Force, actually, and he woke up one day basically with sudden vision loss in his left eye. Didn't have any progenital stage. Obviously, it scared him. He went to the doctor. He ended up getting treated with high-dose steroids. Things calmed down, but once he tapered quickly down off the steroids that they had given him, his other eye was involved. And then, interestingly, shortly thereafter, again, he's 25 years old, his eyelashes and his eyebrows started whitening. He also didn't show a picture of his hair, but he also started getting little gray streaks, so to speak, in his hair as well. So uveitis, why should a rheumatologist care? Well, besides the obvious that, some of our diseases can be associated with uveitis, but it's untreated uveitis is responsible for 10 to 20% of blindness in the U.S., which is a pretty big number. 35% of patients with a history of chronic uveitis exhibit blindness or at least some type of significant visual impairment. Uveitis affects a relatively young population, 25 to 44-year-old, and the elderly in general. And so it's important to realize that this is a serious disease, and it's something that we actually can do to help these patients. So when I started working in the uveitis clinic and working in the eye center, I kind of fell into it, basically. It was somewhat serendipitous because a rheumatologist had left Duke, him and this other ophthalmologist, retina specialist, had started this uveitis clinic back in the late 80s. And he had decided to finally move on from Duke about 4 years ago to take another position in Texas. And he asked me to take his place in the uveitis clinic, and I was happy to do so because it got me out of the frustrating clinic that I was in. So I gladly did so, but I knew nothing about eyes and inflammatory eye disease, so it was a steep learning curve. And the first thing I thought was, crap, I should have paid more attention in med school about the eyeball. So all that said, once I got over that, it became relatively rewarding to help these patients and prevent their blindness and help their vision. So to refresh from med school and to think about the anatomy of the eye real quick before we move on, just think of it kind of like a tennis ball. I would say baseball, but baseball